Today, we're diving into a case that really challenges our fundamental understanding of a specific breast cancer diagnosis. We're talking about in situ cancer, a term that literally means in place. But this story reveals how a disease that's supposedly confined can lead to a fatal outcome, forcing us to question the very definitions we rely on to make life or death treatment decisions.
So here's the paradox, right at the heart of our discussion. How on earth can a cancer that's defined as being in its original place travel through the body and spread? It sounds like a contradiction, and to really get to the bottom of it, we first have to be clear on the textbook definition.
All right, let's get on the same page. Ductal carcinoma in situ, or DCIS, is what we consider stage 0 breast cancer. The idea is that you have these abnormal, malignant cells, but they're completely contained inside the milk ducts of the breast. The crucial part of the definition is that they haven't broken through the duct wall. They haven't invaded the surrounding tissue. They are, by definition, in situ.
But here's the twist. That's the official line. What if a certain group of tumors, which we currently label as DCIS, aren't actually in situ at all? What if they're actually invasive from the very beginning and just happen to look like an in situ pattern?
You know, the best way to understand this isn't through theory, but through a real-world case. We're going to follow a single patient story, and while it's a tragic one, it perfectly captures this diagnostic dilemma and uncovers what could be a fundamental flaw in how we classify this disease.
So check out this timeline. What's really shocking here is the speed. We have a 57-year-old woman with a completely normal mammogram. Just 14 months later, she's diagnosed with what's called a high-grade DCIS alongside an 18-millimeter invasive tumor. Now, she receives aggressive treatment, mastectomy, chemotherapy, but within 2 years, the cancer shows up in her liver. And just a year after that, she unfortunately passes away from the disease.
And just look at this. The image on the left, that's her normal screening mammogram. Totally clear. Fast forward only 14 months, and bam! In the image on the right, you see this brand new tumor that's just appeared. This kind of rapid, de novo development, a tumor appearing out of nowhere, is the first major red flag.
So you have to wonder, was there anything in that initial imaging that could have hinted at how aggressive this cancer truly was? Well, it turns out there was. The answer was hiding in plain sight, a specific visual clue we call a mammographic biomarker.
Yeah, the clue was right there on the mammogram, a very specific pattern that's more than just a simple lump or mass. So what exactly should radiologists be keeping a sharp eye out for?
And this is it. This is the key. These are not your typical calcifications. They're described as fragmented, casting type. And you could see why, right? They look like these fine, linear, almost branch-like fragments that are filling the duct, kind of like a plaster cast that's starting to break apart.
And the really critical thing to understand here is that this pattern isn't just some random finding. It is the direct visual evidence on a mammogram of a very specific and very dangerous process that's happening at the microscopic level.
So what is that process? Well, this is what those casting calcifications actually represent. This is not cancer cells just passively filling up a pre-existing milk duct, which is the definition of DCIS. No, this is something else entirely. This is an invasive cancer that is actively building its own new duct-like structures. The researchers have a name for this process: neoductgenesis.
But if you're looking for the absolute undeniable proof that this was never really an in situ disease to begin with, well, that came later, and it came from the patient's metastatic disease. As tragic as it was, the patient's outcome is what provided the final, irrefutable piece of the puzzle. When the cancer spread to her liver, it gave researchers the opportunity to compare the primary tumor in the breast side by side with the distant metastases.
And folks, this right here, this is the smoking gun. The images on the left are from the original breast tumor. Now compare them to the images on the right, which were taken from the liver metastasis. They are microscopically identical. You see the same key features of neoductogenesis in both, the neoduct cells forming new duct-like tunnels, and that central necrosis inside them. It's a perfect match.
So what does that tell us? The conclusion is just inescapable. The exact same structures that were labeled as part of the DCIS in the breast were the ones that had the biological capability to travel to the liver and form a new tumor. And, by definition, that makes it an invasive carcinoma, not an in situ one. It was invasive from the start.
All of this evidence strongly suggests that our terminology, our very language for this disease, is failing us. That's why the researchers are proposing a new term to more accurately describe what's really happening here.
And they call it neoductgenesis. So let's define it. It's a duct-forming invasive carcinoma. The crucial distinction is that while it may arise from the ducts, it is absolutely not contained within them. It is an invasive process that is capable of spreading right from the get-go.
In this quote from the study, man, it just hits the nail on the head. The term in situ gives clinicians false reassurance and leads to underdiagnosis and undertreatment. That's the real danger. Calling this disease in situ can create a false sense of security, potentially leading to treatment plans that are just not aggressive enough to handle its truly invasive nature.
Okay, so let's pull all of this together. What are the big final takeaways from this incredibly powerful case study and the research behind it?
Well, the clinical takeaways are pretty clear and actionable. First, it starts with imaging. When you see those specific, fragmented casting-type calcifications on a mammogram, that should be a huge red flag that you're not dealing with a true in situ cancer. You are very likely looking at this invasive process called neoductgenesis. And knowing that changes everything. It's absolutely critical for planning the right kind of surgery and the right oncologic treatment. And really, on a bigger scale, this case forces us all to question the terminology itself. Is DCIS always the right term for a cancer with this kind of deadly potential?
And it's so important to give credit where it's due. This critical research, which has such profound implications for patient care, was presented by the incredible Professor Laszlo Tabar and his dedicated research group at Falun Central Hospital in Sweden. Their work is truly pushing the boundaries of our understanding of breast cancer.
And this leaves us with one last big thought. We've just seen how a single medical term, in situ, can mask a deadly reality and completely dictate the course of treatment. It really makes you wonder, doesn't it? What other established terms in our medical lexicon might be giving us and our patients a false sense of security? And what will be the catalyst to finally reevaluate them?